Today, we will be speaking with Dr. John Abramson, who's been on the faculty of Harvard Medical School for 25 years and is author of the new book, Sickening: How Big Pharma Broke American Healthcare and How We Can Repair It. Really great to have you on today, and I appreciate your time.
David, it's a pleasure to be with you. Thanks.
So, when we talk about the modern state of American healthcare, there's many cooks in the kitchen, so to speak, and we can talk about insurance companies, we can talk about big pharma, we can talk about our political system, and there's all of these different factors. In your book, you talk specifically about big pharma. Talk to us about why, as a doctor, that's where you decided to focus in this book.
Right. So I think the biggest American medicine has enormous problems. Our costs are way off the charts. The health of Americans is so inferior to the other wealthy countries that about 480,000 Americans die in excess each year. There's trouble all over the place. I think the biggest cause of this trouble that is unrecognized is the extent to which the pharmaceutical and device industries control the knowledge that doctors rely upon to formulate their ideas about the best way to treat their patients.
So explain how that leads to particular outcomes and disease management, which is often what it is that doctors are doing, quite frankly. What is that relationship?
So let's look at the cancer moonshot issue, which is in the news now with President Biden.
Yep.
The anti-cancer drugs dominate clinical research. They're very expensive. We could cut cancer deaths in half in the United States by attending to preventive therapies, preventive interventions, stop smoking, obesity, environmental risks. So what we're doing, because the money's to be made in developing new drugs and marketing them, what we do is create a body of so-called knowledge that's the results of research that's commercially sponsored, that's about drug therapies for cancer. And the preventive side gets virtually no attention because there's no money to be made in it. What we've got is a market failure where the money is invested in high-cost therapies, whereas the benefit could be reaped much more quickly, less expensive, more effectively by attending to preventive approaches.
So at the primary care level, often an idea is floated that you could compensate doctors not based on the number of things that are done, for lack of a better term, but instead for the sort of successful management of a patient and actually keeping them healthy rather than sick. And of course, the devil would be in the details in terms of exactly how you do it and how you measure and how you compensate. But that's an idea that's mentioned to put the focus back on prevention rather than treatment. Does that not, if you could do that, does that not even really do enough because what you're describing is so widespread and established?
Yeah, it doesn't do enough. It's a good idea. I think that paying primary care docs to take care of people instead of performing units of work would be a good idea. And I think trying to minimize the number of procedures that are done by changing the payment for those procedures is a good idea. And that would be more effective with specialists than it would be with primary care docs. So you could capitate specialists for geographic area, and they would make so much money on salary. And if they did extra, say, cardiac surgeries, they wouldn't make money. If they did extra breast biopsies, they wouldn't make money. So that's one way to approach it. But the core lesion is that the actual knowledge that doctors are trained to trust is invested in because it's going to maximize financial return to the drug companies. It's that knowledge that's the problem. And the idea that that the research projects get turned into articles in medical journals that are mostly written by the drug companies, that are peer reviewed, but virtually nobody in healthcare understands that peer reviewers don't have access to the data, and the guidelines that are written that set the standards for good community practice uh, and can be produced as evidence in malpractice cases if you don't follow them. Those guideline writers don't have access to the clinical trial data. And having spent 10 years in litigation, I know that what's in that clinical trial data, the real data, is often very different from the data that ends up in medical journals. So what we've got is doctors who are compelled to practice so-called evidence-based medicine, which means the bottom two lines of the abstract in the medical journal. That's what they said, without understanding that the whole research enterprise is biased towards making money, that the results aren't peer-reviewed, that the guidelines aren't peer-reviewed, and what the doctors have been trained to trust as the information that's going to best help them take care of their patients is not trustworthy.
There's this example that I haven't read about, admittedly, for a little bit, so I hope I get the details mostly right. And I think maybe it's related to exactly the mechanism you're talking about, which is when it came to cholesterol. There was a point in time, and again, I don't know if it was a couple years ago or more like a decade or 12 years ago, where the sort of line at which point one might consider recommending a statin to a patient was lowered. So basically just the threshold was changed. Nothing really changed about one's likelihood of a cardiac event. Nothing really changed other than instead of saying, I don't know if it was from 210 to 200 or 222, just a change was made. And it was, now if the patient is above this level, consider a statin. I don't know the origins of that change. I don't know if that change was based in what we might call good science, or as you talk about, kind of profit-driven science or something else. But would that be the type of thing that is influencing doctors to make certain decisions that can be very profitable?
That's exactly right. And there are two aspects to that. One is there's never been a study that compared statin therapy to lifestyle intervention. So the drug companies don't want to do that study because they can only lose because they have all the statin business. The other part is that I was the lead author of an article in the British Medical Journal in 2013, which was exactly the time that you're talking about when the standards were changed.
Yeah.
And the numbers for cholesterol, the study results are not transparent. Docs don't have them, guideline writers don't have them. But there's an organization in Oxford called the Cholesterol Treatment Trialist Collaboration that has the data. They made a Faustian bargain with the drug companies that they would receive their patient level data and do meta-analyses on that data. And by combining the statistical power of all the different statin drugs effects in clinical trials, they would be able to show that statins worked for more people. Excuse me. So the CTT receives the primary data, but part of their Faustian bargain was they wouldn't release the primary data. So they control what doctors think they know about these things. So I was the lead author of this article in BMJ, and we recalculated the CTT's numbers that they had published in Lancet that justified lowering the threshold for treating people with cholesterol-lowering medication. And we showed that for people at low risk, who don't have heart disease, who have less than 20% 10-year risk, that there was not a mortality benefit, that their data didn't show a mortality benefit, and that you had to treat between 100 and 140 people for 5 years with a statin to prevent one non-fatal heart attack or stroke. So we wrote that, and unfortunately, we made a little mistake in interpreting the frequency of side effects in a complex study, but it had nothing to do with our conclusion. And the head of the CTT went absolutely ballistic, charged into the BMJ editor's office and demanded retraction of our article, which it was an international kerfuffle. It didn't get much coverage here in the United States, but it sure got coverage in Europe, and it was pretty stressful. The editor appointed a 6-person panel to independently evaluate the demand for retraction. The panel voted unanimously that there was nothing about our article that required or deserved or merited retraction, and on we went. But the CTT, being about 1 million times more powerful than me and my 3 co-authors, had dominated the press, the headlines so long about this attack on statins that we couldn't get our message across to the public, which is, hey, if you are a low-risk person, you may want to take statins, but you got to understand it's not going to improve your longevity. and you have to treat 100 to 140 people for 5 years in order for one to avoid one non-fatal cardiovascular event. And that's your decision. It's not, I'm not saying yes or no. I'm saying doctors should tell patients that that's what the situation is, and let the patients make a decision based on their own values.
Right. To talk about something a little more maybe superficial as it might be within the big pharma space, my dad's a psychiatrist, and he will often talk to me about pharmaceutical reps come to visit, and they bring little footballs, and they bring pens, and they bring, notepads and all of this sort of thing. And they drop off literature, and sometimes there's invitations to lunch, and sometimes there's other things that kind of go beyond that. And of course, there's this very strange dynamic where, on the one hand, if it were straight up said, the idea of the reps is to encourage the prescription of medications, many people would say that's obviously bad. The doctor should simply be deciding on the merits, whether there's a medication that's appropriate for an individual or that it isn't. And then the pharmaceutical companies will typically say that's not why the reps are there. But at the same time, if the presence of these reps made no difference, it doesn't seem like a worthwhile expense for the pharmaceutical companies. So there's this kind of weird dynamic where what are we to interpret to be the point of these representatives? And what do we know about the impact on the rates of prescriptions of drugs when there are versus are not pharmaceutical reps?
Well, that's an easy question. We know if a doctor accepts a lunch that is valued at $20, single lunch, that will significantly change his or her prescribing patterns. So obviously the drug companies aren't stupid, and they engage in this activity because it makes them money. That makes them more than it costs them. The core issue here, it makes no sense on the surface, but the core issue is that doctors in general like to reciprocate politeness and kindness and warmth. And they're not in the habit of being discourteous to people who come saying they're trying to help them. So the drug reps come and they bring information. Some of it is reprints from journal articles. Some of it is glossy charts that are very easy to interpret. But that information is delivered because of its marketing value, not because of its informational value, because that's the information that's selected that will most likely convince the doctor to prescribe or consider prescribing the drug. So we've got a situation where the drug reps are playing one game. They're taught how to shake hands. They're taught how to look in the eye. They're taught how to keep notes about the kids' birthdays and their wives' anniversaries. And they ask all those questions. And the doctors are trying to get the best information they can as quickly as they can to best serve their patients. And it's not a fair fight because the drug reps know that their job is to increase prescriptions. They get bonused on that. They get evaluated on it. They have minders that go out and watch them perform their sales spiel, and they get graded on their sales spiel. So it's a situation that exploits doctors' desire to have good information and innate reaction to be polite where politeness is offered to them. The drug reps know how to exploit the politeness.
What's the lowest hanging fruit here if we were to be able to make some changes to the way this system works, as you talk about a lot of the information on which doctors are making decisions is information controlled by or created and generated, funded by the pharmaceutical companies, all these different things that we've talked about. We haven't even touched on the direct advertising of drugs to people via television, which is almost completely unique to the United States. What's the lowest hanging fruit that would give us the most dramatic improvements?
Yeah, so the lowest hanging fruit is so low that it's a stunning commentary on the power that's controlling American medicine. When a manuscript is submitted to a medical journal, usually the company has played a role in preparing that manuscript, and the manuscript contains a very brief summary of the data from that study. The peer reviewers and the medical journal editors don't get the data to see if the manuscript is accurate and complete. But the manufacturers produce what's called a clinical study report. It's an official document. It's often 2,000 or 3,000 pages long of tabulated data that purports and usually does present the outcomes that the researchers said they were going to study, so they can't pick and cherry pick their outcomes. This is a 2 or 3,000 page document that is prepared and it's searchable. And the medical journals, they complain that they can't do transparent peer review because they don't have the resources to go through the primary data and get statisticians to line up the data with the way the drug company coded it and all that. And there's truth to that. But this clinical study report exists. It would cost nothing for the journals to say, when you submit your article, your manuscript, you must submit a clinical study report. If you want to redact a little bit about how we make the gel code or whatever, you can do that if you think it's a corporate secret. But you must submit that. So why don't the journals do this obvious thing? And once you learn how to get around the clinical study reports, as I did in litigation, it's pretty quick to figure out what's going on. Why don't they do it? They don't do it because they're in an enormous conflict of interest position. They make a lot of their money from selling reprints back to the drug companies for the drug reps to hand out to docs like your dad. So if the New England Journal is going to make $900,000 selling reprints of the Vioxx article that misled doctors and had convinced them that it was safe to prescribe and didn't increase the risk of cardiovascular death, the New England Journal wants to have that article published in its pages and sell 900,000 reprints. If they had the clinical study report, they would have known that the article was misleading, would be too kind a word, but misleadingly omitted 3 heart attacks and didn't present the data on cardiovascular risk. And the New England Journal would have understood that this was a bad drug. It never should have been on the market, and it should have been withdrawn immediately when the results of that study came out. But the New England Journal won't do it because they're going to miss their reprint sales, and the Lancet and JAMA, and that's the way it works. They miss their reprint sales, their advertising revenues will go down, their impact factor will go down. They won't be recognized as the world's greatest journal. So what's happening is the prestige, much like the prestige of MGH Brigham in Boston, where MGH Brigham, they're fabulous world-class hospitals, they spend a fortune on advertising for their branding. And the journals are in the same business of maintaining their branding for their journals. And that means that they're willing to sacrifice the quality of the information that doctors get when they read their journals in order to maintain the branding factor of the journals.
Eye-opening stuff, much of it not the most exciting to read about, but it is important to know what's happening. We've been speaking with Dr. John Abramson, who, by the way, we just lost your video, but we could hear you fine the entire time, and it couldn't come as at a better time. Since this is the end of the interview. Yeah, there you are. You're back. The book is Sickening: How Big Pharma Broke American Healthcare and How We Can Repair It. We're linking to the book, and we really appreciate your time today.
Well, thanks very much for having me.